Hello, dear Dr. Alim and colleagues. Thank you for inviting me and giving me the opportunity to share my journey and insights on the role of anterior segment OCT or AS-OCT in uveitis. Before we dive in, I would like to disclose that I have no financial interests related to this talk. My story with AS-OCT and uveitis began, quite simply, in the clinic. One day, I encountered a patient with a Keppe nodule at the iris pupil border. Out of curiosity, I decided to perform an anterior segment OCT scan. To my surprise, the image revealed something peculiar, a distinct change in the signal at the location of the nodule, an extension along the iris pupillary border that I could not explain. This observation sparked a fundamental question in my mind. What are the iris layers involved in this change? Suddenly, I realized, despite my training and clinical experience, I wasn't sure how to identify each iris layer on AS-OCT, nor could I easily recall their detailed anatomy. It was a gap in my knowledge, a missing piece in my ophthalmic bank. On the very same day, one of our nurses volunteered for a scan, giving me the rare opportunity to compare a healthy iris with that of a uveitic eye side by side. As I compared the two images, the differences in OCT signal became even more obvious. It was clear to me I needed to return to the basics. So I went back to old histology textbooks and classic atlases, searching for a deeper understanding of the iris layers. I reminded myself, the anterior limiting layer, made of fibroblasts and melanocytes, is the outermost barrier. The iris stroma is a loose vascular tissue including the iris muscles. The iris pigment epithelium, with anterior and posterior layers, lines the back of the iris. And of course, the pupillary ruff, which is an extension of the pigment epithelium. This rediscovery wasn't just a matter of academic interest, it changed the way I interpreted OCT scans. I began to see for the first time how inflammation in uveitis disrupts these layers, especially the anterior limiting layer. These early observations motivated me to document my findings. I published my first case report describing how the hyperreflective signal of the anterior limiting layer was lost at the site of the Keppe nodule in uveitic eyes, something not previously reported. Not long after, my work was noticed by Intech Open and other academic groups, leading to invitations to serve as a peer reviewer and later as an academic editor for a book on uveitis. This was a privilege and further deepened my interest in AS-OCT as both a diagnostic tool and a research avenue. Let's briefly discuss the technology behind AS-OCT. AS-OCT uses light to create high-resolution cross-sectional images of the anterior segment, including the cornea, iris, and angle structures. There are two main types. Spectral domain OCT, SD-OCT, which is fast and widely available but often requires an adapter for anterior segment imaging. Swept source OCT, SS-OCT, which uses a longer wavelength and offers deeper, more detailed images of anterior tissues. Emerging technologies like adaptive optics OCT, mainly used for research, promise cellular level resolution. Confocal microscopy offers high contrast for corneal details and chorotic precipitate KP assessment, while AS-OCT provides exquisite detail for the cornea, iris, and angle. It cannot visualize structures behind the iris, such as the ciliary body or pars plana. UBM or ultrasound biomicroscopy can image these deeper structures but requires immersion, is more invasive, and is technician dependent. In contrast, AS-OCT is non-contact and well tolerated, even in children. Let's move to the heart of the talk, what AS-OCT actually reveals in uveitis. I'll discuss this in a layer-by-layer manner. AS-OCT detects corneal edema, band keratopathy, seen as a hyperreflective band with posterior shadowing, and allows us to quantify KP size, morphology, and distribution. Both AS-OCT and accompanying infrared images can be used to objectively measure KP number, size, and reflectivity, offering important clues about the uveitis type. Modern software, such as ImageJ, can help count hyperreflective dots corresponding to inflammatory cells. At present, we can't always distinguish white blood cells, red blood cells, pigment, or debris, but advances in AI promise to improve specificity. This quantification is especially useful for grading inflammation, monitoring treatment, and even guiding steroid tapering. Let's continue with the iris and angle findings. Peripheral anterior synecdoche, PAS, appear as adhesions between the iris and angle, resulting in loss of the normal angle recess. In a healthy eye, the anterior limiting layer is bright and continuous. In uveitis, especially granulomatous types with Kepa nodules, this layer signal is absent. Rather than simple IPE lens adhesion, AS-OCT reveals an extension of fibropigmentary layers from the anterior limiting layer attaching to the lens, a new insight provided by AS-OCT. One of the most striking observations is that with effective corticosteroid therapy, the hyperreflective anterior limiting layer can actually return, and nodules may resolve. However, in cases of chronic synecdoche, these changes tend to persist. In iris stromal atrophy due to herpes uveitis, AS-OCT reveals thinning, smoothing, and sometimes a separation between the anterior and posterior pigment epithelium, offering new insights into disease pathophysiology that need further study. Let's consider some more complex cases. In Posner-Schlossman syndrome, PSS, or other uveitic hypertensive crises, AS-OCT may show thickening of the trabecular meshwork and dilation of Schlemm's canal, helping distinguish between steroid response and primary uveitic ocular hypertension. In ocular hypertension due to corticosteroids, the trabecular meshwork tends to be shorter. A rapidly growing area is AI-assisted AS-OCT analysis, which holds promise for diagnosing masquerade syndromes such as vitreoretinal lymphoma. AI and radiomics can help detect characteristic patterns like aurora borealis or string of pearls. Similarly, in pediatric or silent uveitis, like GIA-associated uveitis, AS-OCT enables non-invasive, objective monitoring of inflammation, reducing reliance on slit lamp exams, and facilitating screening in resource-limited settings. Trials like UviaScreen 1, which is evaluating imaging-based screening for GIA uveitis in children, are paving the way for wider adoption. These approaches can help address disparities in care, improving access to diagnosis and follow-up, especially in remote or under-resourced areas. AS-OCT is also valuable in complex surgical and post-surgical cases, including detecting pupillary membranes, IOL opacification, or capsular distension syndrome. It can detect retained foreign bodies by posterior shadowing and reflectivity, and can assess the location and extension of infection, such as in fungal endophthalmitis related to a scleral tunnel in postoperative scenarios. But it's important to acknowledge AS-OCT's limitations. Mirror artifacts, shadowing, and saturation effects can all interfere with interpretation. OCT currently cannot differentiate between RBCs, WBCs, pigment, or debris, but AI and spectroscopic OCT hold promise. Studies have shown that size matters. Smaller reflective dots tend to be pigment rather than cells. There are also different scan patterns. Square and radial scans have trade-offs. Radial scans may miss small lesions between slices, while reconstructed Y or Z scans can become distorted with dynamic iris movement in square scan images. There is a growing need for standardization. Different patients, variations in iris pigmentation, and differences in device platforms can all affect reflectivity. For example, in patients with albinism, the iris pigment epithelium signal is not evident. We urgently need more normative data. What does the future hold? Robotic, motion, artifact-free acquisition, and contact lens-based imaging may further improve angle and pars plana visualization. Spectroscopic OCT could enable molecular imaging and help differentiate between pigment, RBCs, and different cell types. Normative data collection across age, ethnicity, and iris color will refine the accuracy and precision of AS-OCT in real-world populations. In this way, AS-OCT enhanced acquisition is an evolving process. We need ongoing normative data collection, the identification of morphological and quantitative biomarkers, and ultimately, the ability to gain pathophysiological insight. These advances will enable disease activity and type stratification and move us toward precision uveitis management. To conclude, uveitis has never been a symptom driven disease. It has always required careful clinical examination, making it traditionally observer dependent and highly reliant on examiner experience. With AS-OCT, we are shifting uveitis care from this observer dependent process to an automatic data driven precision subspecialty. Objective imaging enables us to quantify inflammation, monitor structural changes, and guide therapy with unprecedented accuracy. Biomarkers identified on AS-OCT can stratify disease activity, predict prognosis, and personalize treatment, truly bringing us closer to precision ophthalmology. You'll find a QR code at the end of this talk, linking to my recent book chapter for those interested in more details. Thank you for your attention, and I look forward to your questions and discussion.